diagnostic skills. And so, as lab professionals, this you know that we play a critical role in uncovering this silent phase. Through timely and accurate testing, we'll be able to analyze a number of parameters: the urine albumin, the creatinine, the GFR as well. And so, our direct engagement is of great importance. So, colleagues, today our speaker will unmask this and will be able to understand it deeply. Allow me to introduce today's speaker. He's Dr. Taj, and I believe most of our participants who are joining us today have met him in our platforms in other previous presentations. So he's a household name when you talk about lab medicine. He's a renowned scholar and also a writer, and so he's also a lecturer, and so he comes in with vast knowledge on matters lab medicine. He's been giving us a lot of day-to-day hacks for lab medicine, and I believe today we are going to learn something new. And so, Dr. Taj, I hope you're now ready and you can pick it up as we proceed. And by the way, Doc, are you able to put your presentation in slideshow mode? Are you able?
Are you doing?
Yes.
Is it okay now?
Let me wait and see. Let me wait and see. Not yet.
It's in slide now.
Not yet from our side, unless if your network is a bit sluggish. Yeah, true, true. So you can go back to the first page, probably.
Okay.
It's now full. It's now on a full slide mode, and
Okay.
so the slide view is full. So you can probably go back to your first slide so that we proceed.
Okay.
Yeah.
Arthur, thank you. Thank you, Arthur, for the introduction. Um, this webinar today, welcome everyone. I just wanted to jump in, but welcome everyone. We don't have a very big crowd, but we have enough people. This webinar, I want to point out only two things in it. It is a very vast subject, very, very vast subject. We cannot cover it in an hour and a half. I am going to make this webinar just less than an hour, but it will be targeting particularly just two things. One, how can we save the kidney? All of us, wherever you are, either your family member or you know somebody who has got diabetes. Diabetes is now becoming a pandemic. We have all tried to help uh, in the diagnosis of diabetes. We have always tried to help as laboratory people in monitoring so the diabetics lead a good, comfortable life. But this is an additional knowledge now we are getting. And this is what I want to target. Just two things, and I'm coming to them. So here is your first picture, and you will notice that this particular picture is from this company in Germany, and they make urine strips, and they make now 12 parameter urine strips. So I'll come to that 12 parameter as we proceed. But this is a very limited webinar to target only two things where, as a laboratory professional, you play a very major role in the control of diabetes. Okay, so let's just go to the next slide. So we are going to try and unmask the silent face of diabetic kidney. One of the organs There are two organs diabetics have a problem with. One is their kidney, one is their heart. So I'm going to give you the I will start with urine, and then later on we will proceed. Okay. So in Kenya, we have about 800,000 diabetics. A lot of them, half of the, another 40% are not even diagnosed yet. They are waiting to be diagnosed. So that's again the role of the lab, where we are involved in the diagnosis. Okay, let's look at the next slide. So globally, 30% of diabetics, they develop diabetic neuropathy. So in Kenya, if we have 800,000 multiplied by 30%, we're talking of 240,000 patients having diabetic kidney disease. And the role the lab plays in all this is such a tremendous role. But what has happened in the science of nephrology is, now I'm going to show you, which you probably already know, but I just want to emphasize on it. There's been a lot of development in nephrology in the last 10 years. So let's just look. How many DKDs will ultimately need dialysis? So first of all, you start with microalbumin in the urine, then you have more albumin in the urine, then you go into chronic kidney disease, and then you end up in end-stage renal disease. 10% of diabetics usually develop this end-stage renal disease. So we are talking of 80,000 potential end-stage kidney problems. When I travel around Kenya, every central downtown I visit, there is a dialysis unit. The government hospitals also have dialysis units. But here, the role you as a lab professional you'll play can avert, can slow down kidney problems at an early stage, and I'm coming to it. So we are talking of 80,000 people having serious kidney problems. Okay, so when the kidney starts throwing albumin, it is crying for help. If we listen early, we can still protect the kidney and even reverse the albuminuria and have a good quality of life and avoid complications. So I'm going to say this one more time, is that the kidney is telling you that, look, something is wrong, and it's producing albumin, and it is a cry for help. If we can pick this albuminuria much, much earlier, the process can be reversed. There are enough medicines to reverse this. Can the lab assist in early diagnosis and reduce DKD, chronic kidney disease, and end stage, and give the diabetics a better life? Yes, yes, yes. But in the lab, you will have to change. In the lab, you'll have to change your strip. you have to purchase a 12 parameter strip and not 10. 10 parameter strip is now, for the last maybe 7 years now, it is not used in Europe at all. Most European countries are using 14 parameters. But here we are, we are almost every laboratory you go to, they are using whichever country. Some are FDA registered, some are not, but everybody is using 10 parameters. That's where the problem, we want to solve that problem, and we want to give the diabetics a better life. The only way out is to change and go for 12, 13 parameters. The only problem here now is the urine strip you're already using is costing only 15 or 20 shillings per strip. The 13 parameter strip will cost you more than 100 shillings. If you want an FDA quality, it will cost you 200 shillings a strip. A strip. Repeat, a strip. But you are charging the patient 600, maybe 800 shillings. It covers. But why are we going on to that next stage is because of this. In the early stages, the kidney will send you microalbumin, very tiny amounts of microalbumin, and this strip you're using, the 20 bob one, will not pick it. It will not pick that albumin. Only this strip here, the one which is 150 to 200 bob, will tell you there is albumin in it, because the sensitivity of this strip here starts at 300. The sensitivity of this strip here starts at 30 milligrams per deciliter. I'm going to say it again. Everybody uses 10 or 11 parameter strips, which cost 20 shillings. That strip will not pick microalbumin. It doesn't have microalbumin and creatinine in it. The 200 shilling strip has those two parameters extra, and microalbumin will be picked at 30. Here, it will be picked at 300. So you will report no protein, but there is. So the physician will not probably take a further step. Okay. This is the strip. It contains 12 parameters, and here is creatinine, and here is microalbumin. And this strip will pick the albumin at an early stage in the beginning. See, the protein strip is here also. But there is an additional strip here. Even the chemical reaction is different. You can look that up. Once this is picked, and the creatinine is also picked, you calculate what is called albumin creatinine ratio. That will save your patient. The doctor will immediately proceed and try and reverse the whole process. And your diabetic person will have a longer life and will probably never, ever need dialysis. Cost 200 shillings extra. How often? Every 3 months he comes. Okay, so this is the German one. I am holding it, in fact, here. I hope you can see it. It is with me here, the strip. You can visually calculate the ACR. See, creatinine is here. Creatinine is here. Albumin is here. You can visually do this. You can see it can peak at 30. Once it is picked here, or here, or here, you can report the quantity. This is a qualitative report. You don't need a machine, but if you have a machine, it is better. But you can do it visually. So here is the patient, 30, albumin, creatinine 200, is still in the safe area. But if it goes to maybe 150, then you can see it changes. So 150, excuse me, let me get this done. If it is 150 albumin, so it goes in the range of 4. So it will drop. It will drop down to here. Sorry, here. Sorry, go back. So here we are. This can all be done manually and can be done to save your diabetic relative or your parent from further damage before the albumin goes above 300. See here. Okay. Okay, so we are saying, just 1 second, because I'm, okay, gone. The protein pad on the 10 parameter test strip is not sensitive enough to pick microalbumin for the early diagnosis of kidney disease. It only starts picking it up at around here. In spite of that, almost all laboratories are firmly established to use the 10 parameter strip because it's of low cost. And even importers don't want to bring a 12 parameter because it's expensive. But for 200 shillings, you can give a better quality of life to your relative, your parent, and a lot of diabetics. Okay, the clinical advantage, early microalbumin detection, calculation of ASCR, and now this is the second part of my webinar. When you report microalbumin in the urine, your doctor will now proceed to give inhibitors. And one of them, which we are going to discuss at length, is this fellow here, SGLT inhibitors. Wonder drug, miracle drug. Most diabetics, once they are diagnosed, they are normally put on metformin and SGLT. But the monitoring and the early diagnosis is lacking, especially the early diagnosis, because very few laboratories use 12 parameters. Okay, so here is a diabetic kidney. This is what is happening. You collect urine, you do 10 parameters plus microalbumin plus creatinine. So comes to 12 parameters. You calculate the ACR, AUR, and you repeat every 3 months. For those who can afford, you can do HbA1c review, and lifestyle advice is always given. There should be a nutritionist to talk to diabetics. But this part, if you can afford it, get it done. It is just the A1C which is expensive. But then you can replace it with just blood sugar. But this is where your lab plays a major role to make sure that you pick up microalbumin. All right. Every 3 months, you get your urinalysis done with 12 parameter strip. And then, if possible, and if you can afford it, you do a hemoglobin A1C. So we want to, in most medical books now, and what medical doctors are taught, is that you should do your MAO, microalbumin in urine, every year. Now they are changing, the books have been changing. Changes have brought in that now doctors are taught differently. The old school said every year. Now they are saying every 3 months a diabetic should have urinalysis done and microalbumin, and if possible, quantitate it and then calculate the ACR. So you quantitate the microalbumin and then you quantitate the creatinine and calculate what is called albumin creatinine ratio, and it should not exceed 30. But visually, you can do it. You don't need an equipment. You just need a sharp eye with enough light. So these 3 months is to make sure nobody slips through the cracks. Now, in our little hospital setup, we don't only, anybody who comes, say, for example, for a blood sugar or a hemoglobin A1C, everybody is done urinalysis. Standard procedure, 12 parameters. And we even look at the deposit. We are finding that 6% of these diabetics are having UTI and even yeast cell. So here you are, as a lab, you are playing a very, very important role. The patient came, A1C was done, blood sugar was done, urine was done, microalbumin was done, and urine deposit was also done in case there is an infection. So the diabetic is well covered. And this is something you should put it in your SOP, that anybody coming for a blood sugar, urine deposit, urine microanalysis must be done, and urine deposit. Give him a quality of life. Studies have shown that 30 to 40% of patients with microalbumin revert to normal albumin levels after treatment. Revert. I repeat, revert. Give me a minute, please. I just want to adjust something. So 30 to 40% of patients with early diagnosis of microalbuminuria revert to normal albumin levels. Imagine, just imagine. This happens when early treatment is started based on MAO and ACR. The condition is called regressive to normal albinuria. Regressive to normal albinuria. Imagine, 40% can be saved if you, in the lab, as a lab professional, if you are willing to expand your 10 parameter to 12 parameter strip, you will save 40% of your diabetic patients from a lot of misery and even probably dialysis. Okay. Now, this is what has happened in the most important discovery in nephrology has taken place in the last 10 years. And this is where SGLT is coming to it. And I want to explain to you what happens that when a diabetic patient is given SGLT2, what happens? It's an oral HGLT2 inhibitor. It's oral. It's an oral tablet. Most diabetics now are treated with metformin with SGLT inhibitors. I keep on missing it out, but it's an inhibitor. So let's see, what does this magic tablet do? Okay. So these are the names of the different drugs. They're all SGLT. So what happens in the kidney is that there is a renal threshold. So if the glucose passes the renal threshold, that one, the kidneys will remove the extra glucose. But up to the renal threshold, the kidney, the SGLT produced by the kidney will reabsorb the sugar back. Now, this is where the magic is. The inhibitor you're giving orally will block that. So it will stop the glucose to be reabsorbed into the system. So how does it do it? What the magic is, it lowers the renal threshold to half. It's a smart drug. So once it lowers, the kidney does not reabsorb all of it, only some of it. So what happens then? There you are. This is the proper picture for it. This is it, how the SGLT2 works. Look here. This is where it lowers the threshold. So the patient now is producing a lot of urine with a lot of glucose in it. That means your blood glucose has come down, but your urine glucose has become big. You're throwing a lot of glucose out, more than what you should be if you are considering the threshold. So this is the magic. It's an inhibitor. It blocks the natural SGLT. So the reabsorption doesn't take place. It does, but when the threshold has been reduced to half. Okay. So it protects your kidneys. There you are. Sodium glucose transporter is a protein in the proximal renal tube. So it blocks, the inhibitor blocks this transporter. So glucose is excreted in the urine in big volumes, and the threshold is lowered. Blood sugar falls, kidney pressure decreases, heart and kidney protection, and this blood sugar also drops. So by dropping the blood sugar and letting more sugar being thrown out, helps the total system, the whole body now you are treating the whole body. Everybody is being protected. The heart is being protected. The kidneys are protected. The pressure decreases on the kidney. Everybody is fine. Magic drug. Okay. So as I said earlier, 30%, even if they've had, when you discover early protein microalbumin and you tell the doctor, immediately puts her on inhibitors and patient recovers, and with tight glucose control, blood pressure control, reversal, and lifestyle changes, microalbumin and HB measurements, the patient is now having very good full body condition. Although he's diabetic, he's doing very well. Again, it's the same slide. What I'm trying to, as I said right from the beginning, is I have come only in this webinar to tell you two things. One, increase your strips from 10 parameters to 12. Two, understand how SGLT inhibitor works. You can save a member of your family. You can save a diabetic from dialysis. You, as a lab professional, hold this major key. Okay. Okay. So we have 80,000 diabetics. So early detection of MAO prevents progression in 30%. So 24,000 plus Kenyan diabetics would have avoided dialysis altogether. Altogether, if you as a lab professional were using a 12 parameter strip, 24,000, maybe more, maybe double. And the magic drug would have helped. 24,000 people would have been saved from dialysis. Every week, twice a week, you have to go for dialysis. They poke you here, they poke you there, they insert a cannula here and there. All that would have stopped. Microalbumin, once picked, it is treatable, and SGLT will make sure that blood sugar, your threshold is lowered and your urine sugar is increased, but your body sugar is, blood sugar is normal. This is the aim of this webinar. It is a very large subject. I don't want to go into it, but this is what I'm saying. Only you could have delayed and stopped dialysis. You in the lab could have stopped dialysis. Okay. I don't want to go too much into it because this subject is huge. But I want to point out one thing, that when you receive urine in your lab, try and use 12 parameter strips. Quite often, you will see your urine strip saying there is no protein. But when you carefully look at the deposit of the patient's spun urine, you will see casts. So your urine strip is telling you there is no protein, but your urine deposit is showing casts. What is happening here? So that strip is not picking protein when it is supposed to be. So I want to just point out one thing about urine. When you spin urine, it should be controlled. Spin at 200 rounds per minute for 5 minutes. And you must not spin less than 10 mLs. I have gone to many labs in Kenya, and everybody spins 2 mLs, 3 mLs, 5 mLs, not enough. When a patient comes to collect the container from the receptionist for urine, mark it. We want 30 mLs of urine. The container is supposed to be 50, collect at least 30 mLs and spin not less than 10 mLs. Very important. You will not harvest anything clinical if you use 2 mLs and 3 mLs of urine. Don't do it. Go for 10, maybe 12, maybe even 13 mLs. But the speed should be 2000. You spin too hard, you will lose the castes. Okay, Arthur, Arthur,
Yes,
Arthur.
Doc. Yes, Doc. We want to hear you.
I am done, but we seem to have a very big crowd today.
Yeah, sure.
Yeah.
Yeah, sure.
So, what would you like me to do next? Would you like me to repeat the webinar?
Yeah, maybe you can just repeat some critical areas
Yes.
for our participants who maybe came late and maybe didn't get the initial introduction, so that they can at least join the dots and really understand our discussion today. So maybe you can pick on the critical areas, maybe then you emphasize something about them, and then
Yes.
we'll be able to go to the Q&A section, because if we say that you repeat the whole thing, then probably it might also take some time. So you can pick on critical areas that you want us to understand well, so that we also go back to the Q&A and also understand more of these when we ask the question. But we also urge our members to bring in questions. So the questions will also help us to understand this topic deeply. Thank you.
Yeah, it will be good. But I think this is a very important topic, because we are moving from 10 parameters to 12 parameters for a reason. Okay. Okay, so I will say good afternoon, welcome, for those who are not there. The webinar today is not a long one. I took only 35 minutes to finish it, but it is specifically for two purposes: to look after your kidneys as a diabetic. What role does the lab play? What important role, may I say, a laboratory professional plays in preserving the kidneys and the heart of diabetic patients? Okay. So in Kenya, we have more than 800,000 diagnosed diabetes cases, and we have another 400,000 who are probably not yet diagnosed. All in all, we have almost 1 million people with diabetes. Anyone listening to this webinar knows somebody who has got diabetes, either a member of family or a friend. Diabetes is everywhere. So now we have a problem. Is 30% of diabetics develop diabetic neuropathy. So we are talking of 240 patients in Kenya who have further problems and complications with the kidneys and the heart. We look at how many cases do we have diabetic kidney disease? We have 80,000. 80,000. 10% of diabetics eventually develop end-stage renal disease, because it starts with microalbumin and a lot of proteinuria. If not looked after, then chronic kidney disease, and then end stage. This is where the problem is. And you, as a laboratory professional, you can assist in reducing these numbers. Believe me, you can. So we are talking of 80,000 who will end up probably in dialysis. Albinuria in the urine is the kidney telling you and crying for help. please save me. It is when you find albumin in the urine, it's the kidney crying for help. Because finding microalbumin in urine, there are enough drugs now to reverse the whole process, and it will stop. The albumin will stop. It will regress, and your kidneys will be much better and safer. Can the lab assist in early diagnosis and reduce kidney disease, CKD, end stage? Yes, yes, yes. You can give a diabetic a better life, less complication. They even have eye problems. So you have to do something in the lab. The 10-parameter urine strip has to be now left aside and go for 12-parameter urine strip, which detects microalbumin and creatinine. So if your strip is 10-parameter, let's just go to the next slide, you'll see it. This is your strip now. This is the new type of strip, which contains microalbumin and creatinine. Also contains a pad for protein, but this is not sensitive enough for microalbumin. This will start picking your albumin at 300. This will start picking it at 30. The only problem with this strip is that it costs almost 200 shillings per strip, whereas the one you're already using now costs only 15 or 20 shillings. This is where the problem is. But you are charging close to 600, so it's no big deal using the 12-parameter strip. But you are going to save some diabetic problems in managing his kidneys, his heart. So here you are. This is the new type of strip. This is, I'm just giving you the creatinine. Some manufacturers give you 10-parameter strips, and then they give you another strip, which is 2-parameter. So here is creatinine, and here is albumin. And all this can be done visually. It's not a big deal. You don't need a machine, but if you have a machine, it's an added advantage. It can be done visually, and you can do microalbumin and urine creatinine quantitatively. This can be done. It's a turbimetric reaction. It can be done quantitatively. It is expensive, but it can be done. But visually, you can tell. You don't need a machine that microalbumin has started. You see, here is 10, is 30. It is visually visible. The protein pad on your 10-parameter test strip is not sensitive enough to pick microalbumin. But then everybody is using a 10-parameter strip because it's cheap. It's 15 shillings. 12-parameter strip will cost you more than 100, even if it is Chinese. Best use a FDA approved strip. They are available in Kenyan market. Sysmex makes them. ChemLab also imports them. ChemEquip brings them from Korea. They are called YD. There are available these strips. It's not that they are not. They are available. It's only that they cost 200 shillings a strip, as compared to 15 shillings a strip. But then you will save a diabetic a lot of problems and even save him from dialysis. It's worth it. Okay. So I've covered the first part of the webinar, which says that 13 parameter is an advantage strip. It will help your diabetic. And then now I want to go to the second part of the webinar, where we are going to talk about SGLT2 inhibitors. It's an oral tablet. Most diabetics now are on metformin and on SGLT2 inhibitors. So how does this inhibitor work, and how does it gives the diabetic a better quality of life and saves him a lot of problems and perhaps even PKD and CKD. So here we are. This is a diabetic patient. Preferably advise them to come every 3 months and get just their urine test done. By 10 parameter, add the other 2 parameters and calculate the ACR. This can be done visually. If everything is okay, fine. Then if you have a borderline case, you can do hemoglobin A1C, and also you can do a blood sugar. But even in this case here, in the normal situation here, you can do also a blood sugar every 3 months. The medical textbooks I have visited, they all tell you to do MAU, MAU, microalbumin in urine, every 12 months. Now, the same books have been rewritten, and say, do MAU every 3 months, so that you pick it early enough to reverse it. So these inhibitors here, ACE and the SGLT, they can reverse, but I want to particularly talk about SGLT2 inhibitor. Okay. So we have reduced testing urinalysis on diabetics from 1 year to 3 months. And then we want to make sure no patient slips through the cracks. Early injury, you can intervene and avoid irreversible kidney damage. Also, in our small study, we also do urinalysis in all diabetics, whether they come for blood sugar or hemoglobin A1C. Urinalysis is done by 10 parameters, and then again by added 2 parameters, and the urine deposit is looked at. See here, 6% have UTI added value. So the patient is treated and wholesomely goes home. Studies have shown that 30 to 40% of patients with microalbumin revert to normal. So here we are, there is regression to normal albinuria. Just critical point is you must pick it early enough, before even it reaches 300. And then regression can take place. When you pick albumin at a late stage, it becomes very difficult. Maybe it probably doesn't even happen, the regression. So in the last decade, one of the most important discoveries in nephrology was made, and that is called SGLT2 inhibitor. It slows diabetic kidney disease and reduces microalbuminuria. So how does it do that? So this particular drug, some of the names are here, inhibitor, is that the kidney will reabsorb glucose when it is within the threshold. threshold is 180. If it is within the threshold, it will reabsorb the glucose back into the blood system. What this drug does, magic, is that it lowers the threshold. Smart. So it blocks it. It blocks the natural SGLT2. This is a drug you take orally. So when it does that, this is what happens. More sugar is thrown into your urine. Less is reabsorbed back, almost half. So you get urine is 4 plus sugar, but blood sugar is normal. So you have protected your kidney, you have protected your heart, and there is no stress now. So SGLT is something you have to read and understand. So there should be a tight glucose control, blood sugar pressure should be kept in control, reversal medications plus SGLT2, lifestyle changes. The diabetic is now doing well. About 30 to 40% of patients with microalbumin can revert to normal. So this is where we want to, you as a lab professional, you see you can save how many people. The estimated number of Kenya patients whose dialysis could be delayed. Potential end-stage renal diseases are 80,000. Early detection prevents the progression in 30%. That means this 24,000 Kenyan diabetics, you could have delayed or avoided dialysis. They are already on dialysis too late, but what I'm saying in the future, because of doing microalbumin and creatinine ratio, this figure 24,000 could have been saved if you pick albumin early enough. So I just want to mention one thing very clearly. I go around Kenya sometimes and I visit wherever I am, I visit laboratories. And one thing I would like to emphasize on is you must spin urine at 2,000 rounds per minute for 5 minutes, no more, no less, and look at the deposit. But the other thing is most laboratories I visit too, they spin 2 mLs, 3 mLs, 5 mLs. No, you will not harvest enough sediment. You should not spin less than 10 mLs. I would go for 13 mLs. The more, the larger the harvest. Do not spin 2 mLs, please. It is not going to give you any deposit unless if it is a very severe case. Spin enough urine to get a good deposit and look for granular casts, waxy casts, bacteria, yeast. Give diabetics a good life. Now, I don't want to go too much on the drug part of it, but the MAO has a limitation, and the limitation is if the urine is bloody or cloudy, it will show a very high figure. So when ladies are on menses, you have to be careful because the result you give of MAO will be falsely elevated. So it has limitations. If you want to quantitatively do MAO, you can. Microalbumin can be done. you can quantitate it, but visually you can do a qualitative. That's where I'm saying target qualitatively and inform the physician that, look, I found microalbumin. Okay, I don't think I want to go further, but I want to give you some homework, but after the discussion, we will go for the homework. So Arthur, I'm ready.
Yes, thank you. Thank you so much, Doc. That was
Yeah.
wonderful.
Thank you.
That was
Thank you.
wonderful. Yeah,
Yeah.
you did it so well, and I think our participants are able to really appreciate such an excellent presentation. Your depth of knowledge and practical insights have really enriched our understanding of this important topic today. I believe a number of
You
us
liked
are
it.
going to, yes, I believe a number of us are going to think on how they'll be getting the strips and improve from the para 10 to para 13. Now,
Yes.
allow me to go to the Q&A section so that we can answer a few questions that we've received. We have Kenneth Kipsang, who has been locked in. We also have Coril Hillary, who is locked in from Tanariva. We have Kenneth Okubo, who has a comment, and he says, to help aid in early diagnosis, can the board be compelled to enforce the use of 12 parameter kit and phase out the 10 parameters? I think those are discussions that can
Yes,
be
a good idea. Good
escalated.
idea. Good ideas.
Yes,
Mm.
true. Those are discussions that can be escalated further. We have Kenneth Okuba again coming in with a second question. And the question goes, supposing you let a urine sample sediment without centrifuging by staying on the bench for some time, will the results be the same during microscopic observation? And if so, for how long will the urine have to stay? Back to you, Taj.
I particularly want to centralize two things in this webinar, but I would advise Kenneth to look up Monica Chisborough's book and look at it and see what she says about urine being kept to sediment on its own, or using a hand centrifuge, or using an electrical centrifuge. I don't want to go there. I just want to centralize on two things today. 12 parameter strip, and how the whole aspect of nephrology has changed with the discovery of SGLT inhibitors, and what benefits you can get out of this drug. I want to centralize there only. If he wants any more information, you should go to Monica. She will tell you what you need to do for urine sedimentation.
Very well. A question from Steve Kimachu, and the question is the 13 parameter heuristic readily available in the Kenyan market?
Yes, very much so. One of the companies which keeps them is Chemoquip. They are called YD. They are from Korea. Second company, Chemlab, have them. Third company, Sysmex. Whoever is representing Sysmex is ScienceScope. They have the strips. They are ready. Tomorrow you can buy them from Chemoquip. They are available. Tomorrow you can buy from Chemlabs. They are available. But the cost is at least 100 shillings a strip. The Chemoquip one is FDA approved. It's 200 shillings a strip.
Thank you.
Yeah.
Francis Mambili, a good presentation. Khalif Gure has a comment, and he says, I encourage other presenters to make the presentation brief. Because of the brevity, the knowledge sticks instead of large pieces of knowledge that dissipates. Okay, thank you for that word
Thank you.
of encouragement, and also giving us your part of your thoughts. Now we have Margaret Njagi, and Margaret Njagi says very encouraging topic. Margaret is from Embu. We have
Oh, good.
Yes, we have got Kenneth again, Okubo, and he is asking the meaning of ACR and SGLT in full.
Mhm. Oh, it is sodium glucose inhibitor. Sodium glucose transporter.
ACR.
Sodium glucose transporter inhibitor.
What about ACR?
ACR is albumin creatinine ratio. I can show you some slides how to calculate it.
Thank
But
you.
when you buy the strip, it tells you how to calculate.
Yeah, thank you. We have Steve Kimachu again, and he says, does this SGLT2 drug have any side effects or complications?
Yes, yes. Every single drug has side effects and a few complications. The major problem with the sodium glucose transporter is inhibitor is that since you are throwing a lot of urine, since the threshold has been reduced and you are now throwing a lot of glucose into the urine part, there will be some yeast cells, there will be UTI. So there are two major problems there. But it's something you can cope with. You want to save your kidney. You want to pamper your kidney to last longer. You want to avoid dialysis. So the UTI is the price to pay. Fine, no problem. I'll pay the price. But my kidneys, my heart will be safe. The magic thing about the glucose transporter inhibitor is that it lowers the threshold. That's the best part. So you will see blood sugar is normal. So all the organs in your body are now in good shape. But your urine sugar will be 4 plus.
Thank
Okay.
you. Thank you. Point well taken. So another question from Francis Mambili. What is the effect of spin-less revolution per minute? For example, more than 200 RPMs.
2000.
2000, yeah, 2000 RPMs. More than
Yes.
2000 RPMs.
You see, Monica and other research people who have published books like Monica, myself, we all suggest to you that you spin urine at least 10 mLs of urine, not 2, please, not 2, not 5, not 6, minimum 10 mLs of urine you must spin at 2000 for 5 minutes. The reason is if you spin very hard, you will not see casts, they will be broken. Everybody, even if you go to ChatGPT, Google, they'll tell you the same thing. 2000, 5 minutes, minimum 10 mLs. Do not spin 2 mLs of urine and expect that you will see something in the deposit. No, you are wasting your time and you will not see anything. You have to give minimum. There are times when I look at the urine deposit and I say, no, 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 no. I go back to the bottle and I add another 10 mLs and spin it to make sure that I don't miss anything. And the patient should be told by the receptionist, you must collect 30 mLs of midstream urine for me, and you mark the bottle at the 30 ml level. Clearly, the patient must understand, and extra advice is given to women how to collect the midstream urine. So urine is a very, very important part of diagnosis, and it should be collected properly, minimum 10 mLs fun at a specific speed. Please see Monica's book, or if you have one of my books, have a look at it. It's the same speed.
Thank you. Ismail Masita, thanks, Doc. That is on point. I'm learning a lot from your every presentation. Thank you. Hilary Kiprono, thank you, Doc. Be blessed. Lydia Kimutai, thanks. Peter Githigaro, good presentation. Josephine Malala, great presentation. Elika Nangila, thanks, Doc, good presentation. Kevin Namakabwa, a wonderful presentation. And then we have Robert Mwanja. Thanks, Doc. You have Kevin. He says that he will procure the 12 stroke 13 parameter from one of the companies you listed. And
Yes.
then we have Dorcas Adhiambo, very informative indeed. Margaret Njagi, at the package of the 12 parameter bottle, 100 strips, which they repackage with less number to cut the cost, maybe 10 or 20 strips bottle in future. That is a comment from Margaret Njagi from Embu. Then we have David Okoth, Asigo, a very nice presentation. We have got Anthony Obuto. Thank you, good presentation, Stephen Omai, perfect presentation, Doc. Tabi Wambugu, what about this case? Glucose detected in strips, but random blood sugar is normal. Back to you, Doc.
Say that again, Arthur.
Yeah, so Tabi Wambugu is asking, what about this case where a glucose detected in the strip, but random blood sugar is normal?
I am not getting the question well.
So
She's
the
saying
question
that,
is like, in a case where you do blood sugar and then
yes,
the values are normal, but
yes,
then you are able to detect glucose on the urine strip.
yes, good. So it is,
Yes.
the urine has gone above the threshold. That is one. Two, the patient is probably on the SGLT. I don't know, but definitely it does happen even without SGLT, because if the urine goes above the threshold, the kidney will throw it in the urine. But what SGLT does, the transporter, sodium glucose transporter, what it does, it lowers the threshold. So more glucose is thrown out into the urine to preserve the body. That is the wonder of nephrology. That is the best part of nephrology.
Very well. Very well. We have Ralex Otieno, a good presentation. We have Elizabeth Ndungu, the 12 stroke 13 parameter is the way to go. We have
Yes,
Catherine Kanina. Does it mean a diabetic patient with glucose 3 plus in urine is okay? That's a question
yes.
from Catherine Kanina.
If he's on the transporter inhibitor, then it is okay. What basically I'm trying to say here, I'm not trying to say, well, that's what the nephrologist will tell you is that this glucose, sodium glucose transport, there is also another component in this medication. There is sodium, you can hear sodium glucose. So you need to go back and research why sodium also is included here. So this great invention of this beautiful drug is just basically to understand that it lowers the threshold and tries to save the organs. And more and more glucose is thrown into the urine and the blood sugar is brought to normal. So that is the beauty of it. That is the whole essence of this webinar. Go to 12 parameters and study about the sodium glucose transporter inhibitors, what it does. That is the essence of today's webinar. There is more. I'm going to give you some homework so that in the end you can, when you get time, you can open these particular chapters on the net and look at them. But here go for 12 parameter at any cost. You will save somebody from dialysis. Every major town in Nairobi, in Kenya today, has a dialysis center. And probably some of them, those 24,000, probably don't. If they were put on, if the lab discovered microalbumin, and if the doctor had put them on ACEs, inhibitors, and sodium glucose transporter inhibitors, today these people would be walking without dialysis. That is the essence of today's webinar.
Thank you so much, Doc. We have Electin Sileha, a nice presentation. Elizabeth Kipto, wonderful presentation. Have learned a lot, Doc. James Wanyoike, nice presentation. So we are done with the questions that were presented to us. And so I'll take this back to you as we end this session today, Doc. I'll take it back to you. And as you give your parting shot, and maybe as you give us your own homework, you also share with us. Sheila Nekesa wants to know how we can access your ebook. So as you tackle those other the tasks that you have, also tell us how we can access your ebook, and then we will be able to end this session. Back to you.
Thank you, Arthur. You've been very good. Okay, I don't have an ebook yet. I have the physical book, and I can give it to you at 2,500, and I will send. The transport cost is on me, whichever part of Kenya you live. So all you are paying me is really 2,000, and my phone number is 0705 000 324. 0705 000 324. The book, I'll send it to you wherever you are. If you send me money on that Safaricom number, I will make sure that you get the book, but you have to tell me which Nissan comes to your area and your ID number. Okay, parting shot, please spin at least 10 ml. No, let's start. Use 12 parameter strips. They are more expensive, but use them especially on diabetics. 2, learn how to calculate ACR. 3, the sodium glucose transporter inhibitors is something even if we are not into prescribing drugs, but you have to understand how it works, how it lowers the threshold, how it removes the glucose. You have to understand those things, because you will find a lot of diabetics coming with 4+ urine sugar, but the blood sugar is normal. A1C is normal. You wonder what's happening here, So this is a point to take care. But the most important thing is you are in the position to save 24,000 people, diabetics, from going for dialysis. At least some of them. Some may not be possible. Protein may have been found very late and nothing can be done. But if it is found early, if you are using 12 parameter strips, you will be able to help diabetics from dialysis. Dialysis is 2-3 times a week. It is painful, it is expensive, it makes you weak. Your condition as a diabetic, your morale goes down. All that can be stopped if you can use 12 parameter strip. And if you can talk to your doctors nearby and say, I found microalbumin in this patient, please let us work together so that he doesn't suffer. So I want to quickly give you some homework. So one of the proteins which is produced by the kidney is called tam phosphol, THP. It is mentioned in Monica's book, even in my book. This is a protein produced by the kidney. So try and understand this particular THP. It is important to understand this area. Where is this protein coming from? Okay. Now, lately what has happened is, apart from microalbumin in urine, another test has come up, and I think it's been around. Maybe I was informed a little late. It's called Fatwin A fragment. This is an ELISA test, not done in Kenya as far as I know, but it predicts even albumin, even at level of 5 and 10. It is more sensitive than MAO, than microalbumin. It's called Fatwin. It's coming in the market. The only problem is it's a long procedure. It's an ELISA test. So read about Fatwin. It's an interesting thing. What else? Now, this is another area you need to know. Cystatin C. It's more sensitive than creatinine. But read about it. It's interesting. It is something you need to know about. Microalbumin can be done colorimetrically, quantitatively. See here, the microalbumin is being picked, whereas in proteinuria, it's after this figure that your protein strip will pick it up. So this is a patient. His blood glucose was around 5, 7, but urine glucose, because of the sodium glucose inhibitors, this is what is happening. So DKD has a long silent phase. Creatinine is a late marker. Detection of microalbumin, stroke creatinine in urine is now possible. It's about 100 shillings. It's not that expensive, but it is possible now. So this is a friend of mine. He's a professor in nephrology. He's saying that microalbumin occurs in a phase in which the renal damage can still be reversed, provided appropriate medication is prescribed. The screening program for diabetics and people with hypertension at the moment is inadequate. So I forgot to mention also that these drugs are also useful in hypertension. Important, MAO is a symptom of beginning of kidney problems and also a signal for cardiovascular diseases, because CKD is one of the biggest threats of public health in the 21st century. Kidney diseases are too many now. Let's see if there's any other slide. So these are the normal levels for ACR. This is another very good picture. It tells you where albuminuria starts. Okay, so I leave you there. If you need to contact me at all, you can go through Lab Medicine. They have my contact. And I think after this particular all your webinars are on YouTube, isn't it?
Yes, all of them are in YouTube.
Yes. So if you want to listen to it again, you can go to YouTube and listen. And I thank Lab Medicine for giving me this opportunity. I want to thank Arthur and Fred and everybody at Lab Medicine. Thank you for letting me present. And I want to say goodbye, unless if there is any burning question we can answer just now.
I think you've given us a full dose today, and I believe all who attended today's session are happy, and they've appreciated your effort to make us learn. We also request that you make more of such presentations so that you keep on impacting knowledge on us. Otherwise, to our participants, also thank you a lot for joining. We welcome you again tomorrow so that you also join so that we are able to learn again. I believe maybe in a couple of days we'll be having Dr. Taj again. And so to those who will still be interested in having more a presentation, particularly from him, don't wander far. Just be around. I believe he'll be able to make a comeback probably in the next few days so that he can do another round of presentation. Otherwise, thank you so much. And I pray that all of us have a good evening as we plan to meet tomorrow. Otherwise, be safe and have a good evening. Thank you.
Thank you too, Arthur.